कर दो। So, hello friends, I welcome you all for this short series of Physics Wallah, who wants to wish you and make you AIMS Wallah and JIPMER Wallah, and therefore we are having this series which is the INI-CET short series. Now before we actually start with this questions that I have selected for you, there are a few things that I want to discuss with you first, and these are general things that have come over the few years that I have been in this field. So a few general things, and then we will start with the MCQs. So are you all ready? Okay. How is INI-CET different? I will just take 3 minutes for these 3 questions, and then we will start the MCQs. How is INI-CET different compared to other exams? Look, it's going to be an admission to the AIMS or JIPMER or any such institute of national importance, and therefore they expect to be a higher level of understanding and problem solving ability. So therefore always expect at least 20-30% MCQs which have that kind of a problem solving type of attitudes being sought in you. So that's one. Second, most important systems and topics in physiology. So note it down. I'm sure you all are noting down this. General physio, nerve muscle, CVS, RS, CNS and kidney. Or let's keep CNS in the end, because I know CNS takes a long time to finish. And therefore, at least these 5 systems you should focus on the topics or MCQs before the INI-CET exam. So it would be right. So general physio, nerve muscle, CVS, RS, kidney. And if you have already done CNS once, then it should be CNS. But otherwise, no. 5 systems, you will be able to solve most of the MCQs from physiology. Third thing, do the MCQs get repeated at the INI-CET exam? Do they get repeated? MCQs as such won't get repeated. What gets repeated is the topics, and therefore I have selected MCQs today for today's discussion from those topics which are repeatedly asked, although no one can be absolutely 100% sure as to what will be asked eventually, but these topics have been asked in the recent past, and therefore are more likely to be or most likely to be asked even in the upcoming INI-CET. Just one last point, do's and don'ts before the last month or last minute preparation as it is called. First thing, in this last month, do not solve too many MCQs. You noticed my expression, too many MCQs. People will tell you, oh, go on solving as many MCQs as possible. Please don't do that, because more than 50% students came out of the exam every year and they tell me that, sir, I knew the answer, but in the practice test or grand test, I had solved it differently. There was something different about it, and now it came here. Even knowing the answer, I marked it incorrectly. So those wrong options, they have a tendency to get stuck in our minds also, apart from the correct answers. So not too many MCQs. Maybe a light MCQ solving at the end of the day is fine, but not too many. And one last point, and then we will actually start. This is again based on my experience. Do not look at the options immediately. This is my sincere request to you. please do not look at the options straight away. Whenever you read an MCQ, wait, just have a look at the MCQ, the question that is asked, try to figure out what could be the answer, what is actually asked, and then try to solve the answer. Then actually go to the options and see what is best according to you. This is the best strategy for any exam, and to be more precise, even for INI-CET, because topics are repeated, questions are juggled, options are juggled, or something new is given, and therefore only just read the question first. Don't look at the options straight away unless it is absolutely necessary. So let's start. Are you all ready for becoming the AIMS Wallah or JIPMER Wallah, as we are from Physics Wallah conducting these exams for you? Wish you all the best. Right, increased concentration in the tubules. I have selected this MCQ because recently tubular concentrations have been asked for various substances. Now I would just like to keep it simple for this particular session. We will read the MCQ, you try to answer the MCQ. I won't be looking much at the screen right now because that will disturb the flow of the lecture. I am live, I am talking to you live, I am looking at your answers, but we will not go immediately to the all your answers. So what you do is look at the MCQ, answer it, keep the answer with you, and toward the end of the session, last 10-15 minutes, we will see the answers and take your doubts also. If you have any doubts, you can ask me the doubt about any of these MCQ or anything. Okay, so let's start. Increased concentration in the tubules is seen for which of the following? Any answer so far? Okay, now many of you have written answer as C. On what basis are you saying that the answer is C? Look, when there is increased concentration of a substance in the tubules, it means two things. One is either that substance is secreted into the tubules, okay, then its concentration will increase in the tubular fluids, or it is getting reabsorbed, but water is getting reabsorbed at a faster rate. Can you imagine this? This substance A, it is getting reabsorbed from the tubules, but water is getting reabsorbed at much greater pace or concentration. So what will happen? This substance, its concentration in the tubular fluid will increase. Now, which of these substances do you think is giving that? Yeah, now can you think of the answer? You those who have written C, do you want to change your answer to something else? See, glucose is absorbed, and glucose is absorbed 100% from the PCT, okay, in normal healthy individuals. So its concentration in the tubules will not increase. Amino acids also 100% reabsorbed from the PCT. So again their concentration will not increase in the PCT. Those two options are gone straight away. So would you like to, again, I'm just saying, would you, any one of you want to change your answer? It is between chloride and bicarbonate. Which of them is secreted in the tubules? Look, bicarbonate is reabsorbed from the PCT, but bicarbonate is also secreted in the collecting duct by the intercalated cell. You know, in the intercalated cell, in the collecting duct, water is reabsorbed and bicarbonate is secreted. Intercalated cell is a buffering cell in the kidney. It can secrete H plus when H plus has to be eliminated. It can secrete HCO3 minus also. For example, if there is respiratory alkalosis, it will be corrected by the kidney. How? By eliminating the HCO3 minus into the urine. Respiratory alkalosis, alkalis need to be removed, excreted into the urine. And in that case, imagine in the collecting duct, water is getting reabsorbed, but bicarbonate is getting secreted. Overall, all in all, what will happen, you think, to the bicarbonate concentration? Yes, Medico Dreamer is saying bicarbonate this time, and yes, that is the most appropriate answer here. Remember, chloride is getting reabsorbed, let's say 70%, but water is also getting reabsorbed, okay. we are talking about increased concentration in the tubular fluids. If water is getting reabsorbed, then concentration, water getting more reabsorbed and that substance is staying behind, then its concentration will increase in the tubular fluids. Okay, so that was the question number 1. Okay, this is the question number 2. Now this question has come only once, but I expect this question to again come. Okay, here is the question. Calculate the tetanizing frequency from the graph given below. This is a typical AIIMS question. It has come in the AIIMS exam, INI-CET exam. So calculate tetanizing frequency of this muscle. Now look, AB is the latent period. Okay, this is the latent period, means stimulus was applied at A, point A. This is the revolving drum and we have recorded simple muscle curve, a single muscle contraction followed by relaxation. So BC is the contraction period, CD is the relaxation period. Now you have to calculate. I will give you some hint. Okay, tetanizing frequency. What is tetanus? Tetanus is sustained state of contraction and failure to relax. In a skeletal muscle, there is a sustained state of contraction and failure to relax which occurs from high frequency stimulation. High frequency, the word is high frequency stimulation. Okay, and I have given this example in many of my videos, that when you are writing an exam and you write very rapidly, very fast, toward the end, at the end of 2.5 hours, your muscles, hand muscles, go into sustained state of contraction. They fail to relax for some time. What is it? It is physiological tetanus. Okay, sustained state of contraction, failure to relax, which occurs from the high frequency stimulation of the muscle. So far so good, no problem there. Now tetanus, how can you calculate tetanizing frequency? At what frequency the muscle will go into sustained state of contraction and failure to relax? It is calculated as the reciprocal of the contraction period expressed in seconds. Okay, tetanizing frequency is equal to 1 upon contraction period. My writing is much better than this, but please bear with me for just 1 second. Contraction period expressed in seconds. Okay, tetanizing frequency is equal to 1 upon contraction period expressed in seconds, reciprocal of the contraction period. So now watch the graph. I have already told you BC is the contraction period. So you just have to know how much is this time BC. So anybody calculating so far? Okay, I'll give you the further hint. What is this, you think? Ye kya hai? What is this? Some kind of a design, some kind of a diagram. What is it? And they have written 100 cycles per second over here. So can you recall something from your first year? 100 cycles per second. So listen, let's complete this. Okay, and please note down your answers and then you can again check it later. Tuning fork with a frequency of 100 cycles per second is you strike the tuning fork, frequency 100 cycles per second, and apply it to the revolving drum. The drum is rotating. You might have seen the Sherrington Starling drum. So when you hold it near that drum, you get 100 such cycles per second. 100 such cycles in 1 second. Okay, that's the tuning fork frequency. So these 100 cycles in 1 second. Now can you tell me? I am looking at you. Okay, most of you are giving correct answer, right answer actually. 100 cycles in 1 second, that means duration of one cycle will be how much? 1/100th of a second, isn't it? Or 0.01 second, correct? Now this cycle, one cycle, such cycle has got a duration of 0.01 second. Now simple, BC is the contraction period. Below that, how many cycles are you seeing? most of you have come up with the correct answer. So anyways, Dr. Dipanshu, Dr. Sashikala, surgeon, yes, correct. So BC is the contraction period, and below this contraction period I can see 3 cycles, 1, 2, 3. If one cycle is 0.01 second, then 3 cycles will be how much? 0.03 seconds. Okay, so contraction period in this given graph has to be calculated like this, 0.03 seconds, and final tetanizing frequency is 1 upon the contraction period. So 1 upon 0.03 seconds, that will be 100 upon 3. That is, most of you have written the answer, yes, 33. Therefore, the answer was 33 times per second. If this muscle is stimulated 33 times per second, then it will go into tetanus, sustained state of contraction. So I just appeal to you to remember the word high frequency. Tetanus means sustained state of contraction, but which is occurring from high frequency stimulation. Once you know that, you have to know what is the frequency. Okay, and frequency is number of stimulations per second or per unit time. So that is what was asked, and I expect a similar MCQ even this time. So prepare the tetanus, tetanizing frequency, skeletal muscle curve, and all those graphs. Once again, just quickly go through them. No need to go into the details. Okay, question number 3. I hope you all can see the question. Okay, question number 3. Least number of movements are seen in which part of the gut? Least number of movements are seen in which part of the gut? Okay. Have you heard of BER? Basal electrical rhythm. Basal electrical rhythm is those electrical potentials occurring with a certain frequency in the gut, in the various places of the digestive tract. Okay. Now BER, that frequency of electrical excitations, that frequency is different in different parts of the digestive tract, and that frequency is responsible for these movements number of times per minute. So now you can just think about BER and come up with the answer. Anybody? Yes, surgeon is correct. Dipanshu Kalra has also, Dipanshu seems to have read very well. Dipanshu Kalra, very good. Stomach, even surgeon again is correct. It's the answer A, that is stomach. So just by heart the BER frequencies, because this time I expect something related to the basal electrical rhythm in the digestive tract. By the way, I'm just asking you one quick question. All of you are vigilant. Answer this question. Just write those 5 letters which I am asking. The pacemaker cells in the digestive tract is. Pacemaker cell in the digestive tract is. Don't write the full name. Maybe just last name, last word. Pacemaker cell in the digestive tract is, come on, interstitial cell of Cajal. So I expect something related to this, because digestive tract is overdue. Not many questions have come in the recent past, so probably this is the area to watch out for. Interstitial cell of Cajal, not Kajal, but Cajal is the cell which is responsible for those electrical potentials and their frequency. Okay. Now the BER frequency you may note down quickly. Stomach, the BER frequency is 3 to 4 per minute. Okay. Then duodenum, jejunum, ileum. Okay. Duodenum, jejunum, ileum, the frequency goes decreasing. 12 per minute, 9 per minute, 7 per minute, and this is responsible for those peristaltic contractions and number of movements, and therefore least number of movements are seen in which part of the gut? Yes, many people have written Cajal, Kajal. Yes, Jiten Yadav, Shubhendra Talukdar. Yes, correct. That's right. So highest frequency is seen in the duodenum. By the way, there is a law related to this. Do you remember? Law of the gut. Law of the gut. law of the intestines. It says oral to anal direction of the peristalsis. That's the natural way of peristalsis, and it is because of this decreasing frequency of BER, 12 per minute, 9 per minute, 7 per minute. By the way, just adding one more MCQ here so you can think and answer. The only place in the digestive tract where antiperistalsis is seen naturally, normally, is which place in the digestive tract? And you want the options? Options are the stomach, duodenum, ileum, colon. You may just answer. I am looking at your answers. Although we had decided to keep the time in the end, but yeah, anything? Natural antiperistalsis is seen in which part of the digestive tract? Look, antiperistalsis results in vomiting. Okay, you all know that, but that is in abnormality. Somewhere in the digestive tract, antiperistalsis is natural to occur. Can you answer? Colon? Yes. Arey, kya baat hai? Fantastic. Yes, that's right. From the hepatic flexure of the colon to the cecum is the place where antiperistalsis is naturally seen. Peristalsis, antiperistalsis, and then again peristalsis. This gives the time for the colon to absorb as much water as possible and to finally form the fecal matter. Okay, therefore that antiperistalsis is quite natural to happen over there. Okay, let's go on to the next MCQ. Here is the question. Which of the following will be present in the glomerular ultrafiltrate? Which one is like most easily filterable substance? Take it like that. Which one of these can be easily filtered at the glomerulus and therefore it will be found in the glomerular ultrafiltrate? I am waiting for your answers, and also I am discussing that there is a glomerular filtration barrier. Okay, glomerular filtration barrier, and that glomerular filtration barrier, let's say here is a glomerular capillary. Okay, here there is, we will require some good space, so let's go to the space here. Glomerulus, this is a capillary in the glomerulus. Okay, and these are the endothelial cells. There are some fenestrae between the endothelial cells. All right, so filtration is going to take place here. But three components of the glomerular filtration barrier are endothelial cell, then the basement membrane on which this endothelial cell is located. This is the basement membrane, and outside the basement membrane there is this cell, epithelial cell. Remember which one? Podocyte. So the food processes of the podocytes. These three form the glomerular filtration barrier. Now look, there are negative charges on those endothelial cells as well as on the basement membrane. There is a glycocalyx. Okay, there are glycocalyx situated here, and the glycocalyx has a negative charge, and therefore negative will repel. So remember this, anions will be generally repelled by these negative charges and cations will be attracted more and more. So cations will get filtered easily. That's point number one. And the point number two is that, see these fenestrae, they have a certain size, and because of the size they can filter the substances only up to a certain nanometer diameter, like 8 nanometer diameter, only up to that. Beyond that they cannot filter out. So if a molecule is small and if it is polycationic, then it can be easily filtered and it will be found in the ultrafiltrate. So you had to know these two properties of the glomerular filtration barrier. Have you come up with the answer? Yes, correct. Dr. Dipanshu Kalra is reading very well. It seems he has given a correct answer. Lesser the radius and more positive charge. Precisely that was what I was talking about. Okay, let's go on to the next question. Okay, next question is kind of an exercise instead of a ABCD thing. So you will have to mark one, and let's say here we will write ABCD. Okay, where is it gone? Yeah, this is A, this is B, this is C, and D. So depolarization is caused by which of the following? A, B, C, D. Excess potassium exit or what, or sodium influx or whatever. Options are in front of you. Just look at the options. Depolarization. So 1, what? A, B, C, D. Then 2, repolarization. What? A, B, C, D. After depolarization. What? A, B, C, D. And after hyperpolarization. A, B, C, D. Are you all writing? 2 is certainly D. No. Depolarization. Dipanshu. You have written 2 and D. Repolarization. I think you meant 1 and D. See? Depolarization is caused by what? Okay. Note this point here that I expect one question from action potential. Absolutely every exam, one question from action potential has been asked. It's like a must. They ask sodium and potassium currents. They will ask about some property of the action potential, something like that. So please note down, quickly go through the action potential once when you are revising physiology. Okay, mark my words, one question from action potential is again due in the upcoming exams. Okay, so depolarization is caused by the sodium influx. Then repolarization is caused by the potassium exit. So D, then followed by A. Now that leaves us with after depolarization and after hyperpolarization. So give me just 30 seconds to explain this part. After depolarization and after hyperpolarization. Look here, graph of action potential in a nerve. So from minus 70 to plus 35, depolarization. That is because of the sodium influx. Gone, no problem there. Repolarization, that is because of the potassium exit. Gone, no problem there. But this part is called as after depolarization. Okay, after depolarization is a misnomer. Actually, it's a part of repolarization, but still somehow it is called as after depolarization. After depolarization is the actually slowdown of repolarization. So come on, tell me, at the start of repolarization, let's say potassium concentration gradient was 145 on the inside and 4 on the outside. So potassium started going out rapidly and therefore repolarization is occurring rapidly initially. But then if it slows down, what must be the reason? Concentration gradient for potassium narrows and electrical gradient gets created in the opposite direction. So net potassium exit slows down. Okay, so remember here at this point repolarization rate has slowed, and that is because of the fact that potassium concentration gradient will narrow after early exit. Okay, and then after hyperpolarization. Hyperpolarization is because of what? All of you can answer this in chorus, no problem there. Hyperpolarization, excess negativity inside because excess potassium ions leaving the cell. Okay, that was okay question, but I expect there may be some question related to sodium potassium currents. When do they happen? What is threshold, etc. So please go through that once again. Okay, next question. Calculate the respiratory quotient in a patient with the respiratory quotient in a patient with the following data. Okay, here is the data, by the way. CO2 exhaled 200 ml per minute, O2 consumed 250 ml per minute. Calculate the respiratory quotient. Now I want to add one thing here. Just adding one thing. Sometimes they may give you a faltu data. Faltu data means it may not be of any use. It's just given there to trouble you. Yes, that's quite possible. Any such data present in this MCQ? You find out, I don't know. But calculate the respiratory quotient from the given data. Body weight 50 kgs and then CO2 exhaled this much and O2 consumed 250 ml per minute. So what is the respiratory quotient? We had a professor who used to pronounce the words exactly they appear. Respiratory quotient. I still remember the professor. But yeah, what is it? Respiratory quotient is, okay, let me give you the formula, then you can come up with answer. CO2 evolved per unit O2 consumed. Okay, that's the respiratory quotient. CO2 evolved per unit O2 consumed. Its viral end fact is correct, 0.8. Dr. Dipanshu, you are about to be right, but I think 200 upon 250 it should be, and that is 0.8. Yes, so all of you have now gotten up and started giving correct answers. That's very good. Your path for the AIMS and PGI and JIPMER, yes, we are getting more and more towards that direction. Okay, so respiratory quotient. Now I will ask you one additional question. For a fat-rich diet, what will be the respiratory quotient? Come on, I am looking at the screen. Even as I go to the next MCQ, I will wait for your answers. For the fat-rich diet, what will be the respiratory quotient? Any idea? Anything? For the fat-rich diet, what will be the respiratory quotient? No answers so far. Okay, so please remember, for the mixed diet, see, basically what is the respiratory quotient? We consume nutrients, and those nutrients are metabolized in the presence of oxygen, and therefore and the metabolic end product carbon dioxide is liberated. That is why we calculate it like this. That is CO2 evolved per unit O2 consumed. CO2 evolved per unit O2 consumed. But it will differ from nutrient to nutrient. Look, fat, when you eat fat, it is always burnt aerobically. Fat will be always oxidized aerobically. It will consume more oxygen and relatively liberate less carbon dioxide, and therefore fat-rich diet, yes, many of you have written correct answer. Fat-rich diet, it will be 0.7, not 0.8. And for a carbohydrate-rich diet, the respiratory quotient will be 1.0. Okay, just remember like this, 0.8 for a mixed diet, but for the fat it is less. Why? Because in the case of fat oxidation or fat metabolism, it consumes more oxygen. It is oxidized aerobically. It consumes more oxygen and relatively less carbon dioxide is generated, and therefore the value becomes less. Okay, because denominator is more. And for carbohydrate rich diet, it is 1.0. I expect one question from GIT, so I selected 2 or 3 GIT MCQs also. Give the sequence of the following events after the P wave on the ECG. Are you all reading this? Come on, read it. If you can read this, give the sequence of the following events after the P wave on the ECG. Okay, so P wave, then followed by A wave in the JVP. First heart sound, rapid filling of ventricles, T wave. You have to write it A, B, C, D, whatever is your sequence. Yes, Dr. Dipanshu has written correct respiratory quotient for all the nutrients correctly. So now, check it out. P wave on the ECG. Come on, tell me one thing very honestly. How many of you are still thinking that depolarization means contraction and repolarization means relaxation? Do you still think like that? I know many students who are interns, also post-interns, they have read physiology a lot of times, but they still talk like this, means it's a loose talk. Depolarization means contraction, no. Repolarization means relaxation, no. No, that's not correct. Anyways, leave that for some other time. We are interested in the MCQ. So, first the electrical event will occur, then the mechanical event will occur. I think Jiten Yadav, Sasikala ke viral end fact, viral end fact has written only C. But anyways, whatever you have written is the correct answer actually. So here, ECG, electrical changes occurring in the heart, and P wave means atrial depolarization. Okay, I expect question on this. I expect question on ECG and related things, cardiac cycle related things, JVP also. So please mark my words, one question has to be there from cardiac cycle and related events. Cardiac cycle is a must. Any exam, if you have just one day to read CVA, 1 day to read physio, read cardiac cycle. It is that likely. Okay. So P wave on the ECG. So atrial depolarization will be followed by atrial systole, atrial contraction, and atrial systole is marked as A wave on the JVP. Remember JVP, A wave is caused by atrial systole. So P wave on the ECG will be followed by atrial systole. And then the ventricular events will start. At the start of ventricular systole, there is isovolumic contraction, closure of the semilunar valves, and that will produce the first heart sound. Did I say semilunar valves? Okay, closure of the AV valves. This is a gimmick which is played by many teachers just to see whether you are awake. Okay, and then you point out, hey, he made the mistake. It's good, actually. Point out, you should be awake to check for the mistakes. Anyways, first heart sound at the onset of ventricular systole. So after the atrial systole, there will be ventricular systole, and then the electrical event in the heart, T wave, ventricular repolarization, and finally ventricles will relax. That will be the last phase. Okay, after the ECG and the cardiac cycle, most of it is over. This will be the last phase. So most of you have written the correct answer, that is A, B, D, C, and I told you why. First the electrical event, then the mechanical event. Remember like this, and then first the atrial event, then the ventricular event. Remember like this, and then any question asked in any manner and you will be able to answer. Before we proceed, I just want to give you one small suggestion. Please correct your circadian rhythm. I have been saying this for a long time that students make this mistake. Please regularize your circadian rhythm. On the day of exam, it won't be a good idea that you were reading till 4 o'clock and then getting up and then going for the exam. No, your neurotransmitters will not be fully functional. I mean your synapses where you stored the information. Okay, next, question number 8. Which of the following is a transport through the cell membrane? Come on. Transport through the cell membrane. Anybody? Transport through the cell membrane? Okay, I'll give you a hint. Till you are reading the options, this is just a hint. Transport through the cell membrane and transport across but not through. Okay. Transport across the membrane but not through the membrane is one, and transport through the membrane is another. When actually a substance invades the membrane and goes through the membrane. So which of these is transport through the cell membrane? That means other three are not actually transport through the membrane. Clathrin mediated endocytosis, is it? No, it is transport across the membrane. Pinocytosis, is it? No, it is transport across the membrane. Solvent drag and constitutive exocytosis. Now we are left with two. Which one? Ooh, so far no answers, no correct answers. Okay, so that means I need some explanation I need to give some explanation on this. Look, when you say transport across the membrane, just quickly write it down and remember this forever. Okay, I expect at least one MCQ on transport processes. Okay, it will be on GLUTs, or it may be on sodium potassium pump, or it may be on something like this. Okay, so please read the transport processes fully, extremely well before this INI-CET. Now look, here is a cell membrane and the substances cross the membrane to go either into the cell or from inside to outside. So they are crossing the membrane. So basically all transports are transports across the membrane because all of them are crossing the membrane. Okay, so across. But some substances, they invade the membrane, they go through the membrane. They invade the membrane and they go through the membrane. The other substances move without actually going through the membrane. So substance was here, it comes to this side but without actually going through the membrane. How does that happen? By forming a vesicle. Some part of the membrane will form a vesicle like this around the substance. Okay, and finally this part will be pinched away and the substance will be internalized inside the vesicle. So please remember, endocytosis and exocytosis, these are vesicular transports. Okay, and all these vesicular transports are transport across the membrane but not through the membrane. Okay, they don't actually go through the membrane, invading the membrane. So that leaves us with what choice? Solvent drag was the answer. Let me tell you what transports through the membrane are osmosis, diffusion and active transport. These are called as transports through the membrane. Yeah, diffusion, lipid soluble substance, it diffuses through the lipid bilayer. Okay, so it is a transport through the membrane, diffusion through the lipid bilayer. Okay, so I hope you have understood the difference between transport across and transport through the membrane. Osmosis, when sodium goes, water follows. So water movement through the membrane is called as osmosis. What is solvent drag? Water moves in bulk and it drags the sodium. That also is an opposite of osmosis, and but therefore this is also very much solvent drag is a transport through the membrane. Okay, basically please read the transport processes through, across. Particularly I would appreciate if you read factors influencing the rate of diffusion. There are 9 factors, and that active transport, co-transport, counter transport. Please read these, they are extremely important in every exam and even for upcoming INI-CET. Which of the following increases in COPD? Come on, all clinicians get up and start writing, start giving the answer. I mean, you all are finished your medicine, your interns, post interns, so clinical stuff must be perfect, and therefore I am sure this will be answered correctly. What is it? Which of the following increases in COPD? FRC, TLC, VC and FEV1. Any answers? Anything? Which of the following increases in COPD? Anything? Oh, placebo is saying B, but others are saying D. Jiten Yadav is saying A. Okay. Anyways, which of the following increases in COPD? Look, FEV1 decreases in COPD. You know, obstructive airway diseases. What happens in the obstructive airway diseases? Expiration is more difficult. Okay, inspiration is relatively easy, but the positive pressure, right? So please understand and remember like this forever. In COPDs, expiration is difficult, inspiration is relatively easy. Point number 1. Point number 2 is, because expiration is difficult, there is early closure of airways. Early closure of airways during expiration. There is early closure of airways during expiration, which means what? Which means suppose you inspired 500 ml of air with inspiration. Okay, expiration being difficult and there is early closure of airways, all 500 ml may not be able to come out during expiration. I am talking about COPD. Okay, in COPD, all the air that inspired may not be able to come out because of that early closure of airways, and therefore what increases is the residual volume. Residual volume goes on increasing. Okay, and therefore most appropriate answer in this case is FRC. Oh, actually I wanted to answer these questions in the end, but anyways, residual volume increases because 500 went in but only 450 came out, so 50 extra stayed back there in the lungs, and therefore in this way residual volume and FRC will increase. There is said to be trapping of air beyond the constricted airways. Okay, so please remember, it may result in emphysema, which is a later stage, but for now this was the answer. Let's go on to the next question. Come on, where is that gone? Oh, okay, question number 10. Here it is. Okay, now I also expect one question from sarcomere and related things. So what are, read the question and try to answer the question. Which among the following leads to detachment of myosin head from the actin? If you want the hint, no, I won't give you the hint. You think over this. Which of the following leads to detachment of the myosin head from actin? Okay, which leads to relaxation of the muscle. Myosin detachment from the actin and muscle relaxation. But for that, what should happen? Release of ADP and PI, attachment of ATP to myosin head, attachment of ATP to actin. Oh, anyways, this is Diwali bonus. Only 3 options. Answer the question now. Which one is it? Oh, some of you are writing A, but no. Wait. I'll give you a hint. Then you can answer. Can you think of rigor mortis? What is rigor mortis? Myosin head remains attached to the actin. Why? Because there was exhaustion of ATP. Why was ATP needed? Because attachment of ATP on the myosin head. Myosin head, remember, myosin head has ATPase. You forgot that? Myosin head has ATPase. At least remember now. This enzyme is present in myosin head. So ATP will bind to myosin head, and then ATPase enzyme will break down that ATP. That energy will be utilized for myosin detachment from the actin. Didn't I tell you rigor mortis? Why the myosin head remains attached to the thin filament? Because ATP is exhausted. So please remember, attachment of ATP on the myosin head is necessary, and myosin head has ATPase enzyme, and that's the reason for rigor mortis, exhaustion of the ATP. Okay, next question, question number 11. Counter current flow is seen in which of the following? Counter current flow seen in which of the following? Come on. Skin, kidney, testes, intestines. And you have to answer like this. Okay, D option is all of them. So D has gone below. But anyways, you can see these 3, and last option is all. So 1, 2, 3, 1, 2, 3, 2, 3, 4, 1, 3, 4. Tell me which one will show or will not show. Skin, does it show counter current flow? Yes, it does. Kidney, obviously it shows counter current multiplier, counter current exchange mechanism. Testes, does it show counter current? Yes, it does. Look, counter current flow in these 2 cases, testes and skin, they are required for heat transfer. Okay, the function over there is for heat transfer. So one function of counter current flow is heat transfer, exchange of temperature, exchange of heat. Kidney, counter current flow, counter current multiplier and exchanger, that is for concentration of urine. Does intestine show any counter current? No, it doesn't. Intestines, rather than exchanging the materials, intestines are mainly required in absorption of the nutrients and taking them away further into the general circulation. If such thing is required, then the counter current will not be required. Okay, so answer is, many of you have written the answer, I think. B, 2, 3, 4. Oh, some of you have written B, some A, 1, 2, 3. Correct. A is the right answer actually. Wrinkle Totlani has written correct answer A. Skin, kidney, testes, they definitely require counter current. Skin and testes, okay, for heat transfer. I will add one more option to this. Please note it down. All you clinicians, interns, please note it down. An additional option. Dialysate in the dialyzer shows counter current flow. You may add it, or you already are aware of it. The dialysate in the dialyzer, it shows counter current flow. Dialyzer, blood, counter current flow. Okay, as I said, whenever there is exchange required, you will require counter current flow. In the dialysis process also, the things are to be removed, the things are to be added, there is exchange of materials. That is where you will require counter current flow. Okay, and therefore intestines have to be one-way transport. Nutrients are absorbed and they are taken away into the general circulation. Mostly, I mean, in most of the cases, of course. So intestines in that sense would not show counter current. Okay, next question number 12. I hope all of you are very vigilant. You can read it, you can answer the question. Yes, hello sir. Mohammad Shair is saying hello sir. Hello, welcome. Okay, read out. Identify the correctly matched pair. Again, I have selected one more question related to transport processes because it's always a must in the INI-CETs, in any exam for that matter. So, correctly matched pair. Simple diffusion moves, which substance moves by simple diffusion? Oxygen, they have said. Facilitated diffusion, calcium into sarcoplasmic reticulum. Primary active transport, glucose, and ion channels, oxygen. Oh, oxygen has come twice. A, everybody is writing A, and yes, absolutely correct. Simple diffusion, oxygen transports by simple diffusion. Right. Oxygen diffusion, simple diffusion of oxygen occurs through the lipid bilayer, and that is how it occurs. Facilitated diffusion, calcium into sarcoplasmic reticulum. Can you tell me, can you just write it here? I am looking at your answers. Calcium into sarcoplasmic reticulum is what type of transport, you think? Calcium into sarcoplasmic reticulum. What type of transport it is? I just wait for your answers. You want options? Okay, options are primary active transport, secondary active co-transport, secondary active counter-transport, or facilitated diffusion. Just to see whether you have this funda very clear. How is calcium transported in the sarcoplasmic reticulum? Primary active transport, secondary active transport, secondary active co-transport, secondary active counter-transport, or facilitated diffusion. How is calcium transported into the sarcoplasmic reticulum? I can't see any answers. Are you all there? Come on, knock knock. Who's there? INI-CET. Come on, it's waiting for you. Koi hai? Okay. So I guess that is left to me to explain. Calcium pumped into the sarcoplasmic reticulum is by primary active transport. It is calcium ATPase, calcium pump. Okay, so please note it down. I will just quickly draw it for your attention. This is a sarcoplasmic reticulum. T tubules, L tubules. Calcium is released by an interaction between DHPR and RYR, but that was not the question, so I am writing it small. Calcium is released, it combines with troponin C and it initiates the process of contraction. But after that, calcium is removed from the sarcoplasm and sent back into the sarcoplasmic reticulum by calcium ATPase. It's a primary active transport, calcium pump or calcium ATPase. Okay, that was required to be known. Primary active transport, glucose. Glucose, I think glucose, they say na, done to death. This is done to death, means done a number of times. अभी उल्टी आ जाएगा, इतना बार वो glucose का question आ चुका है. Glut. So please read the gluts once again properly. Which glut is used where? You want it as a quick revision for INI-CET. Here is the quick revision for you. Glut 1. Constitutively expressed glucose transporter is glut 1, and it is ubiquitous, omnipresent, atra tatra sarvatra, everywhere. So that is glut 1. Okay. Glut 2. Pancreatic beta cell. Glucose entry into the pancreatic beta cell occurs by glut 2. Also, I have said this in the videos. Please watch. Oh, you have the exam now, no time to watch the videos. So please remember, whenever glucose has to leave the cell, it uses glut 2. Okay, glucose has to mostly enter the cell. Okay, fine. But sometimes glucose also have to leave the cell to come into the blood. That time it uses glut 2. Then glut 3. Neurons have glut 3. And glut 4, I am sure all of you will answer in chorus. Glut 4 is meant for what? Yes, insulin dependent glucose transporter, glut 4. So glucose has been asked a number of times. Clerks have been asked a number of times. They ask you like this, like that, like this. For example, a patient came in a dehydrated state and you gave him ORS. ORS has glucose. How will that glucose be absorbed from the digestive tract? Same thing is being asked. Glucose absorption from the gut, GIT. Okay. Next question. Which of the following is not a cause of central cyanosis? All right, all right. Oh, yes, yes, yes. Okay, I am waiting for your answers. I got the message, Dr. Dipanshu. We are some time behind and we are writing the answers. Okay, okay, my apologies. I am looking at the screen, but this is the problem, and therefore I said that we will have a chat once again in the end of this discussion. Okay, so you keep on writing. I am watching your answers and I am taking them as the answer to the currently discussed MCQ only. So that's okay. Okay, so which of the following, all of you are now at question number 13. Okay, which of the following is not a cause of central cyanosis? Look at the options and give me the answer. Is it methemoglobinemia or pulmonary AV connection or hypothermia or high altitude? Which of them? Okay, okay. So you are on time now, Dipanshu. You are on time, Dipanshu Kalra. Answer is C. Yes, I can see that. Answer is C. Hypothermia results in peripheral cyanosis. You have all gone through the clinical stuff, and I am a physiology person, so I need not explain this in very detail. But just for the sake of confirmation, central cyanosis and peripheral cyanosis, and one way to distinguish between the two is immerse the hand. Suppose you see the cyanosis on the fingertips, immerse the hand in the warm water. If that cyanosis disappears, that is peripheral cyanosis. In fact, central cyanosis is seen here on the lips and oral cavity, because this is always moist, warm and moist, and even if cyanosis is present there, in spite of the fact that it is warm, then this cause must be the central cause for cyanosis. Okay, so hypothermia, all of you have given the correct answer. Let's go on to the next question. Match the following transporters with the molecule they carry. Okay, oh, you will need the molecules also, right? Here we go. Okay, I'll read it out. If it is too small, I'll just read it out. Hemopexin carries what? Haptoglobin carries what? Prealbumin and albumin. 4 transport molecules are given: hemopexin, haptoglobin, prealbumin and albumin. And what do they carry? Hemoglobin, thyroxine or bilirubin? Which one is carrying what? Come on, you tell me. I'll look at the board and I'll look at your answers and write down. Hemopexin carries what? Okay. Haptoglobin carries what? It's a transport for, I am looking at you, I am looking at the answers. Okay, anyways, that it will take too much time for typing of this answer, so I'll answer this question myself. Hemoglobin haptoglobin complex, you know that already. Haptoglobin is a transport globulin. Prealbumin and albumin. So thyroxine and bilirubin, these two things are remaining. Thyroxine is carried by which one? Prealbumin as well as albumin. Thyroxine binding globulin, thyroxine binding prealbumin and thyroxine binding albumin, or albumin also carries it, but we have bilirubin also in the options. So what you will say now? Albumin, bilirubin, and thyroxine binding prealbumin, TBPA, you know, so there will be thyroxine. Thyroxine is bound by TBG, TBPA and albumin. So this was the sequence. I think this was a very straightforward one, so let's not wait at that. Next question, question number 15. All right, question number, oh, where is it gone? Okay, question number 15. Yes. What will happen to the alveolar ventilation? What will happen to the alveolar ventilation when pH is changed from 7.4 to 7.3 at PaO2 of 100 mm of Hg. Normal PO2, and suddenly the pH is changed from 7.4 to 7.2, 7.3, 7.4 to 7.3. What will be the result? Increased ventilation, decreased ventilation, no change in the ventilation, or first decrease then increase? Oh, you saw the answer. I hope you didn't see the answer. Yes, you are slightly behind. I am going ahead. I am watching your answers, don't worry. And many of you have written correct answer. Yes, you have come to the next. Placebo has given a correct answer, that is increased ventilation. All of you writing yes. 15 answer is A. Surgeon is writing question number also. Good strategy. Yes, 15 ka answer is A, increased ventilation. And why is that? Acidosis, I mean changing to the acidic pH, and that means protons have been generated, H plus has been generated. Can you just write here H plus has slightly increased, okay? So pH has moved towards slight acidity from 7.4 to 7.3. These arterial H plus, they will stimulate ventilation via what? By stimulating what? I'll wait for you. I'm waiting for you. Increased ventilation is right. This is moving towards acidosis, acidemia or acidosis, and arterial H plus increases. So I'll wait for you. Just type it. Arterial H plus stimulates what? To stimulate the ventilation. Anybody? Okay. Which receptors I am asking? Look, ventilation increases via two types of chemosensitive cells, chemoreceptors. Peripheral chemoreceptors and central chemosensitive area or central chemoreceptor. That is what I am asking. Arterial H plus, I repeat it third time. Arterial H plus is known to act via which of these? It stimulates what? Peripheral chemoreceptor or central chemoreceptor. You can write P or A. P or C, peripheral or central, just to save time. Arterial H plus stimulates the ventilation via peripheral chemoreceptor, okay? So, hypoxia and arterial H plus, metabolic acids, they stimulate the peripheral chemoreceptors, carotid bodies, and central chemosensitive area is stimulated by the CO2, arterial CO2, which crosses the blood-brain barrier, enters the CSF and forms the H plus locally. Okay, that was the small little question that I had asked. Okay, peripheral, central, some of you are writing central, some of you are writing peripheral. Anyways, question number 16. So, come to the question number 16. Identify A and B. Okay, what is A, what is B? Now this diagram has become little shabby because look, these are all recall questions. When the students came out of the exam hall, they described to us, this was the diagram, this was it, that was that, and from based on that we draw the diagram. Okay, sometimes you will find only 3 options or something like that, because these are all recall type questions. Now come to the diagram. This is a transport protein in the membrane. First thing, it has got 5 binding sites. Okay, see, 1, 2, 5 binding sites over there. 1, 2, 3, 4, 5. 3 binding sites on the inner aspect, 2 binding sites on the outer aspect of the membrane. This is what is being shown in this diagram. Plus ATP is getting bound. So this is a pump. This is a pump, means pump or ATPase, and 5 binding sites. So mostly it is a sodium potassium pump. So that leaves us with only one thing. What is A and what is B? So write down your answer. Oh, you wanted options. Sorry, I obstructed the options here. My bad. Okay, these are the options. A is what? B is what? Oh, you have written the answer also. Placebo, Amit. Answer is A. Yes. Sodium binds to the pump on the inner aspect of the membrane. and potassium binds to the outer aspect of the membrane. Total 5 binding sites, 1, 2, 3, 4, 5. 4, 5 on the outside, potassium binding site and ouabain binding site. Cardiac glycosides will bind to those sites. Okay, question number 17. Look at the question number 17. Which of the following acts by increasing the phospholipase C? Okay, here are your options. Here are the options. GS, GQ, GI or none of the above. GS, GQ, GI or none of the above. Which of the following act by increasing phospholipase C? 17 ka answer surgeon is writing as A. Anybody agrees with that? I disagree. Again A. Oh, phospholipase C. Huh? Come on, we are talking about GPCR. Think about G protein coupled receptor. B. Yes, answer is B. Actually, Amit has written the correct answer. So look, a quick summary of the G protein coupled receptor. The receptors in the membrane are of two types. Okay, one is GPCR, G protein coupled receptor. याद है ना, 7 transmembrane segments, 7 times it spans the membrane, serpentine receptor. Okay, and this is coupled to the G protein, which is called as heterotrimeric G protein. Okay, so alpha, beta, gamma, 3 subunits. This is that complex. This is the serpentine receptor and it is coupled to the G protein, GTP binding protein. It has 3 subunits, alpha, beta, gamma. That's right, you know that. Now this alpha subunit, whenever a hormone binds with the receptor, alpha subunit separates from the other 2, beta and gamma, and then it will give rise to an effector protein inside the cell. You know all this. Okay. Now talking about this alpha protein, this is of 2 types, in fact 3 types, but let's first understand the 2 types. GS alpha, that is stimulatory, okay, and GQ alpha. Okay, when this GS alpha is present, then it moves and it will activate adenylyl cyclase enzyme, and adenylyl cyclase enzyme will activated and it will increase the cyclic AMP levels inside the cell. Okay, so that is GS alpha. Also remember, GI alpha is also there. I is inhibitory, so that means if this alpha subunit GI alpha is there, then it will inhibit the adenylyl cyclase and that will decrease the cyclic AMP levels inside the cell. And I'll tell you the classic example of that. Decreasing the cyclic AMP, exerting the effect by decreasing the cyclic AMP is classic example norepinephrine. Norepinephrine, particularly acting via alpha 2 receptors, okay, is a classic example of inhibition of adenylyl cyclase, and that is via GI alpha. Okay, G protein alpha subunit and inhibitory, G protein alpha subunit and stimulatory. So increase cyclic AMP, decrease cyclic AMP, inhibitory. Now coming to this one, GQ alpha. Look, if this alpha subunit is GQ type, Q type alpha subunit, then it will not activate adenylyl cyclase enzyme, but it will activate phospholipase C enzyme. Okay, so we have 2 such pathways. One is adenylyl cyclase pathway, the other one is phospholipase C pathway. And phospholipase C, if it is activated, then let me just write it here. When that GQ alpha is stimulated, or rather it moves along the membrane, it got dissociated from the beta and gamma subunit, and then it activates phospholipase C enzyme. Okay, and when this is activated, it will form 2 byproducts inside the cell. I mean, first of all, it will act on phosphatidyl inositol biphosphate. Phospholipase C enzyme will act on phosphatidyl inositol biphosphate, and that will convert into two compounds. One is inositol triphosphate and dialkyl glycerol. So this is another second messenger system. One was that cyclic AMP, the other one is this phospholipase C. But the point was GQ type of alpha. GQ alpha will activate phospholipase C. Okay, please read it. Okay, question number 18. All of you, question number 18. Come on, come back. Get up. Start smelling the coffee. The INI-CET is nearby. Chalo. Two vessels, one with diameter D and the length L. Another with the diameter 2D and length 2L. Then flow in the second will be how many times that of the first? 4 times, 16 times, 32 times, 8 times. Oh, 4 times, 16 times, 32 times, 8 times. What say? Okay, I think you all are giving the answer already. Yes, this is based on fourth power law of the radius. The flow in a tube is proportional to r raised to 4. So r कह लो या diameter. Okay, if the diameter or radius is doubled, see, diameter is doubled, the flow will increase by how many times? 2 raised to 4. Okay, whether you take diameter or radius, it's okay. So when the diameter is 2D, the flow will increase by 2 raised to 4, that is 16 times. This question has come a number of times in different ways. So please read the fourth power law of the radius. They have asked it a number of times. Okay, one more. Now this question, question number 19. I am waiting. All of you are yes. Question number 19. I will wait for your answers. Read the question. I am waiting for your answers. Use of transcutaneous nerve stimulation. Oh, the word was transcutaneous electrical nerve stimulation. TENS. TENS. You know, you have heard of it. Transcutaneous electrical nerve stimulation. TENS is used to relieve pain. Is an example of what? Question number 19. I am waiting for your answers. You can write 19 and then the answer. Is it conditional pain modulation? Is it central sensitization? Is it gate control theory of pain, or descending analgesia system, or descending pain inhibitory system? What is it? 19. Question number 19. Come on. Placebo is writing C, and I am waiting for other answers if they want to differ from him or her. This is an example of what? TENS, TENS, transcutaneous electrical nerve stimulation, is an example of alleviation of pain or analgesia, acquiring analgesia by gate control theory of pain. Yes. Now Wrinkle Totlani has also answered C, and that's right. Answer is C. Look, gate control theory of pain, for some reason, I don't know why, in last 3-4 INI-CETs it came in different forms. I remember, I think it was 2019 when 2019 or just before that, there was this MCQ. A football player injured and his knee was hurting, then he rubbed the thigh area and the pain was relieved. So what is the theory involved in this? Gate control theory of pain. Then last time there was a diagram on gate control theory of pain. If you remember, I'll just show you that diagram which was asked in the INI-CET, and it is likely to be repeated. They had shown this diagram and they were saying that a football player was injured and his knee was hurting, as I mentioned. It was next year, this question. He started rubbing thigh for some time, applied pressure on the thigh, and the pain was relieved for some time. What could be the site of action of this particular thing? And they gave options. Option number 1, option number 2, option number 3, and option number 4. This is on the dorsal horn of the spinal cord. These are the commissural fibers. This is the anterior motor neuron, and this is the lateral spinothalamic tract. Number 4 is the lateral spinothalamic tract. This question was asked with this particular diagram. So can you write anything about this? A, B, C, D, or 1, 2, 3, 4. Gate is located where? Just write that. Gate is located where? Here, or here, or here, or here. The answer is, some of you are thinking answer is 4 because that is lateral spinothalamic tract. No. So just let's understand this gate control theory of pain. The answer was, this is the diagram that came actually in the exam. Okay, so please look at it once. Answer is A, this one, because this is the dorsal horn. Okay, and the gate is situated in the dorsal horn. Gate is situated in the substantia gelatinosa of Rolando or Rolandi. Some people call it Rolando. So just quickly go through this once. Again, asked 3 or 4 times in last 4-5 exams. So this is worth looking at. See, this is the dorsal horn. So pain carrying fibers will enter through the dorsal horn. Now on the dorsal horn there are laminae. Okay, lamina 1 is lamina marginalis, then lamina 2 and 3. Lamina 2 and 3 are together called as substantia gelatinosa, and this is the site for the gate control for pain transmission. So here is a pain carrying fiber, enters the spinal cord through the dorsal horn and ends in the substantia gelatinosa. Another pressure carrying fiber carries the pressure sensation. You know, pressure points are applied in acupressure. So pressure is applied and it enters the spinal cord and causes a presynaptic and postsynaptic inhibition of the pain carrying fibers. So when you apply pressure over here, the pressure, the signals related to the pressure, they will enter the spinal cord and they will close the gate for the pain fibers. So analgesia will be felt for some time. That is the gate control theory of pain, and therefore you know, those I'll show those 4 points which were shown in the diagram. So this was point number 1 and that was the answer, substantia gelatinosa. That is the gate for pain transmission. Then second neuron starts from here, crosses the midline, goes to the opposite side and then ascends upward as lateral spinothalamic tract. So they gave this also one more site and this as one more site, but the gate closed only here in the first order neuron, ending on the second order neuron and inhibiting the pain. Okay, and the fourth was here, anterior motor neuron. Not interested. Okay, next come to the next point. Wrong statement about the following about accommodation changes in high altitude ascent is. So which of the following is wrong statement? All of you are writing and I am watching your answers. So please look at this. When there is ascent into the mountains, high altitude, which of the following is wrong? Oh my god, I gave the answer. No problem. You can just read it. Is it metabolic acidosis or pulmonary vasoconstriction or hypoxia or respiratory alkalosis? Which of them will not occur? And the answer is, I think some of you saw the answer. Therefore, let's write it. Its answer is A. Why is that? Because high altitude will result in hypoxia. Yes, we all know that. So hypoxia will be definitely there. Hypoxia leads to pulmonary vasoconstriction. Yes, we all know that. You know, hypoxia causes constriction in the lungs, but dilation everywhere else, dilation of the vessels. But lungs, it is pulmonary vasoconstriction. So B and C are quite obvious. Respiratory alkalosis, yes. Hypoxia will stimulate ventilation, and ventilation stimulated means CO2 and H plus will be washed out of the body. CO2 washed out means H plus washed out. CO2 is volatile acid. So H plus washed out means it will result in respiratory alkalosis, and therefore B, C and D are going to definitely happen at the high altitude ascent. In fact, respiratory alkalosis is expected, and there are drugs given for that. Acetazolamide is also given before the start of ascent. So all this is already known to us. Let's move on to the next question. There are only a few questions left now, and then I'll give you the chance to answer those questions. Dipanshu Kalra is asking what happens to the O2 HB curve, oxygen dissociation curve. Dr. Dipanshu and all of you, if you want to know, please note it down mentally and note it down in the book. During ascent, the curve is shifted to the left. O2 dissociation curve is shifted to the left. And during acclimatization, the curve is shifted to the right. Are you noting it down? Please note it mentally at least. During ascent, the curve is shifted to the left. Remember, oxygen is taken and hemoglobin will hold that oxygen. Okay. So during ascent, the curve is shifted to the left. And during acclimatization, how do we acclimatize? RBCs will form more and more 2,3-diphosphoglycerate, and that increased 2,3-diphosphoglycerate will shift the curve to the right. So remember, during ascent, shift to the left. During acclimatization, shift to the right. Okay, question number 21. Oh yes, that reminds me. Oxygen dissociation curve is another very important topic. Please don't miss it for this INI-CET. Okay, please don't miss it. Okay, for a 4-year-old child weighing 15 kgs, now 21 number. Okay, roll number 21. Not roll number. Question number 21. I am waiting for your answers. Look at the question. For a 4-year-old child weighing 15 kgs with serum create 1 mg% and serum urea 100 mg%, what is the closest approximate to the GFR? Yeah, 80, 50, 40, 30. What is your answer? How will you solve it? Can anyone spell that formula? Anyone spelling that formula? Anybody? I'm waiting. Okay. So the formula is Cockcroft and Gault formula. Cockcroft and Gault formula. Can you now solve this MCQ? Cockcroft and Gault formula says that creatinine clearance is equal to 140 minus age into body weight upon 72 into plasma creatinine. 140 minus age into body weight upon 72 into plasma creatinine. So plasma creatinine is given, age is given, body weight is given. Put those values into the formula, and yes, surgeon has written Cockcroft. Yes, Cockcroft and Gault formula to calculate the GFR. Basically, it is to calculate the creatinine clearance, which will be an approximation for the GFR. Okay. So, क्या आ रहा है answer? Answer anyways is 33. Now so you can calculate. So no problem there. But what I want is you to understand the Cockcroft and Gault formula was required. Okay. Here weight is given and serum creatinine given. So you have to know what is to be applied. And I told you some time back, some data is given just to trick you, like serum urea. It's given, but it's not used here in this formula. Okay. Next, question number 22. I am waiting for your answers. Which of the following is post-synaptic? Okay. Which of the following is post-synaptic? So 3 events will be pre-synaptic, 1 will be post-synaptic. Identify that. A. Norepinephrine action on the alpha-2 receptor. Long-term potentiation in the hippocampus. Post-tetanic potentiation in the cortical neurons for the short-term memory. and sensitization to a life-threatening or important stimulus. Which of them is the post-synaptic event? Question number 22. So you write 22 and write ABCD. 22, write ABCD. Oh, it's looking little dull. Okay, I see. Okay, it is dull. Norepinephrine action on the alpha-2 receptor. Is it presynaptic or postsynaptic? Long-term potentiation in hippocampus, pre or postsynaptic? Post-tetanic potentiation, short-term memory of cortex, pre or postsynaptic? And sensitization to a life-threatening or important stimulus, presynaptic or postsynaptic? Question number, Shubham Tiwari is writing C. Hariom Shah is writing C. Is it for this question? Question number 22. Okay. Oh, placebo has come up with the correct answer. Well done, placebo. Placebo, Dipanshu, all of them are giving correct answer. Wrinkle Totlani is giving correct answer. Yes, Dipanshu, I was waiting. NEET class 12 has written D, but no, D will be a presynaptic event. I'll just quickly tell you what these are. So, norepinephrine action on the alpha-2 receptor. Alpha-2 receptors are called as presynaptic receptors. Okay. See, those who have not done it, probably some of my first prof students are also attending. So for them, look, this is the synapse. Okay. Synapse releases neurotransmitter, and neurotransmitter is supposed to act on the receptor. Receptor is located on the postsynaptic membrane, but no, there are certain receptors which are called as autoreceptors, presynaptic receptors or autoreceptors. They are located in the presynaptic membrane. And what is their job? What is their function? To decrease the release of the neurotransmitter. That is their function. So these are called as presynaptic receptors or autoreceptors. The neurotransmitter will bind to it and will cause feedback inhibition of the further release of neurotransmitter. The classic example is norepinephrine acting via alpha-2 presynaptic receptors. Alpha-2 presynaptic receptors, they cause inhibition of further release of norepinephrine. So ये presynaptic event है. Post-tetanic potentiation in the cortical neurons, presynaptic event, because see, what is post-tetanic potentiation? If you stimulate a synapse tetanically at high frequency, impulses are going, and therefore calcium comes into the presynaptic neuron and calcium accumulates in the presynaptic neuron, and because of that there is a great release of neurotransmitter later on. So that's called as post-tetanic potentiation. But basically it happened where? In the presynaptic neuron. Calcium accumulated in the presynaptic neuron. Sensitization, habituation, if you have read the learning and memory, there you will see habituation, sensitization, increased release of neurotransmitter by the presynaptic neuron when there is a life-threatening stimulus. So that's called as sensitization. And again, it's a presynaptic event. Only B is the long-term potentiation in hippocampus. There is increased calcium influx resulting in long-term potentiation and long-term memory. That is a postsynaptic event. Okay, this is my favorite question. I hope some of you must have seen this question. Okay, I'll decrease the zooming. This is my favorite question. जो इसको आंसर करेगा उसको मेरी तरफ से एक सलाम. 2 scenarios of muscle contraction are shown here. Write question number 23 and then I'll show you the options also. Okay, look at this, A and B, 2 scenarios, 2 muscles, and load is being applied to these 2 muscles, muscle A and muscle B. Look at them carefully and now answer this question. This is my favorite one. Okay, जो सही आंसर करेगा उसको मेरा सलाम. तो इसके लिए पूछ रहा हूँ. देख लिया, Okay, I'll show you the options and then we will come back again. Scenario A is preload, scenario B is afterload. What say? Scenario A is preload, scenario B is afterload. What is it? Is it true? Anyways, we will go to the next options also. Work is done in A but not in B. Work done is load into displacement. So work done is done in A but not in B. That is one more question. That was the option number B. A is isometric contraction, B is isotonic contraction. Watch it. A is isotonic, B is isometric. And oh, Hariom Shah is saying too hard question. But when I explain this, and why did I select this question for today's discussion, you know, I am anticipating one question from preload afterload series. Okay, it could be in the skeletal muscle of physiology, it could be in the pharmacology, the venodilators and arterial dilators, those who decrease preload, those who decrease afterload, or it could be in medicine. But I expect one question on this scenario, so please look at it. Koi hai? More heat will be liberated during A. That was the last option. So A, B, C, D. Question number 23. A, B, C, D. Question number 23. Dipanshu is writing C. That is A is isometric and B is isotonic. Oh, just close. But yet not correct. Okay. Okay, Shahid is writing B. B, work is done in A but not in B. In fact, work is done in B but not in A. I will explain. So B is gone, C is gone. Koi hai abhi or anyone who wants to give this answer? The answer is, oh, there are too many people with option B. But I'm afraid the answer, I'm still waiting for some of you to answer question number 23. Anyways, don't bother, the answer is A. Scenario A is preload, scenario B is afterload. And it was not too tough, okay? It is not very tough. Look how. What is preload? Start thinking in your mind. What is preload? What is afterload? Preload means load starts acting on the muscle in the resting state. Okay, even before muscle contraction begins, load starts acting on the muscle. That is called as preload. Before the contraction has started, means what? In the resting state. What is afterload? In the resting state, the load is not acting. But when the muscle contraction starts, load starts opposing that contraction. So load starts acting on the muscle. Now look here. Scenario A. This is resting muscle. This is a resting condition shown here clearly. Muscle is not supported at all. So when you apply the load, what has happened is the muscle got stretched. Which means what? Which means load has started acting on the muscle straight away during its resting condition. See, the muscle is not supported at all. So when you apply the load, the muscle has got stretched. Stretching of the muscle means the load started acting on the muscle in its resting condition only. Compare that with scenario B. In the scenario B, this is the resting condition. Means muscle is supported here. Support has been shown. Load was applied. And see what has happened next. The muscle has shortened. See, the muscle has shortened in scenario B. So you need to understand this very, very clearly, that muscle contraction means shortening. Itna to aapko pata hai na, you know this. So muscle contraction means shortening. So where the shortening of the muscle has happened? See, load was applied and muscle has shortened. Muscle has shortened and it has displaced the load. So that is after load. And this is, oh, this load has moved. The load has moved by itself. load into displacement, work done. Anyways, let's bring it back. It was here. Okay. So this was preload. Load was applied. This is resting condition. And see what has happened. The muscle has got stretched. Stretching is not contraction. Okay. Stretching is not contraction. Shortening is contraction. When muscle contracts, it shortens. So here, no contraction has been shown in scenario A. Just the load applied and muscle was stretched. Okay. So scenario A is preload. When load was applied in the resting condition, the muscle got stretched. And that is after load. Work is done only in B and not in A. Many people argue, I have done this before, so many students argue that sir, but even in this condition load has been displaced, so work is done on even in A. No baba, work done by the muscle. When muscle contracts and displaces the load, that is load into displacement caused by the muscle. Here load has been displaced but not by muscle contraction. Okay, muscle was unsupported, so only the load got displaced like that because of the stretching of the muscle. That's it. But please read preload and afterload also from the muscle chapter. Okay, last question in our discussion, and then I'll see if you have any questions, and that will be all. Question number 24. A syrinx is growing in the central canal of the spinal cord. First sensation to be affected will be which one? 24. Question number 24. Give me your answers A, B, C, D. A syrinx is growing in the central canal of the spinal cord. So, first sensation to be damaged will be which one? The answer is of course is. Anyways, let's not wait for the answer anymore. The answer is pain and temperature. Pain and temperature. I'm sure some of you might have written the answer already. The answer is pain and temperature. What's happening? Okay. Answer is A. So let's discuss that. And that will be all for the MCQ part. I expect one question from CNS, and it is mostly from the Brown-Séquard syndrome or this type of a question. Okay, Brown-Séquard syndrome, spinal shock, or this syringomyelia or damage to the dorsal columns. So watch it. The syrinx condition is syringomyelia. Okay, syringomyelia. There are cyst-filled lesions in the spinal cord. So here is a cyst-filled lesion, okay, in the central canal, this spinal cord central canal. This is the condition called as syringomyelia, and this is called as syrinx, the cyst. And such a cyst is known to grow mostly anteriorly in this direction. So which fibers will be the first one to be damaged? Pain and temperature. Obviously, watch it. Fine touch, pressure, vibration, proprioception. Carried by dorsal columns. Fine touch, pressure, vibration, proprioception. Carried by dorsal columns. See, they enter the spinal cord, then they turn backward and they start running upward. They are placed dorsally in the dorsal white column. Now look at the pain and temperature. Pain and temperature fibers enter the spinal cord, then the first order neuron ends there. Second neuron starts from there, crosses the midline through the anterior commissure and reaches the lateral white column and then starts running upward. Watch it. That syrinx, which is growing anteriorly, is going to kill means damage the pain and temperature fibers, because they are carried like this through the anterior commissure. So please read for this particular exam the dorsal columns and Brown-Séquard syndrome and anterolateral tract, pain and temperature, etc. So pain and temperature will be the first to be damaged. And I think that's all for today. If you have any doubt, I'll wait for it in any question. Otherwise, that will be all uh, for this particular session of INI-CET. Of course, if you have any doubts, you can ask us on the PW social media platforms. I'll be very happy to answer those questions. Till your exam, we are accompanying you. Physics Wallah accompanies you and wants to make you, as I said in the beginning, AIMS Wallah, JIPMER Wallah. I mean, hope you get the admissions over there. All the best, all the best, all the best. This was the Physiology Sure Shot. Oh yes, can you please list all the important topics to revise? Yes, I'll take just this question because this is really important, and that will be all for this particular session. So just go on writing. These are the topics that you you must follow. That was not an echo. I did it deliberately. Till the time you take your pen and paper, or till I get my correct place to write. Yes. Write down 5 systems. Revise 5 systems. General physio, nerve, muscle, CVS, RS, kidney. And if the time allows, then CNS. Okay, 5 systems or 6. General physio, I told you already. Transport proteins like GLUT, etc. and sodium potassium pump, and transport processes across the membrane, through the membrane. Then, oh yes, one thing that we missed actually, but anyways, you can read it even now. Body fluid compartments. We really missed that. But I thought that I have discussed these body fluid compartments a number of times in recent days. So I thought same students attend all these sessions. So I thought this is repeated a number of times. Body fluid compartments. Yes. Then nerve muscle. Nerve muscle. Classification of nerve fibers. Erlanger and Gasser classification. Remember A alpha, A beta, A gamma, A delta, and B and C. And which fiber is prone to which type of injury, etc. Then muscle. Okay. I think we will save time. I'll tell you. You can go on writing. Muscle, excitation, contraction, coupling, sarcomere. These 2 things from the muscle, and contraction, theories of contraction. Wrote 3 things: EC coupling, sarcomere, muscle contraction. So nerve, muscle. Then CVS, cardiac cycle, blood pressure, and cardiac output. 3 things: cardiac cycle, blood pressure, cardiac output. 3 things, very important. Conducting system, you may read arrhythmias in the medicine, or you can read it in physiology. So I make it 4: conducting system, cardiac cycle, cardiac output, and blood pressure. 4. Then RS, 3 important segments: mechanism of breathing, O2 transport, and O2 dissociation curve. Very important. O2 transport and neural regulation of breathing. That section is taken here. Mid-pontine transaction, this, that. So please do that. Okay. Mechanism of breathing means lung volumes, capacities, gas transport, O2 transport, and neural regulation of breathing. And that was RS. Then the last was kidney. So GFR, renal circulation, and tubular functions, and bladder. GFR, tubular functions, renal circulation, and bladder. That cystometrogram. Nowadays it is being asked. So these 4 topics from kidney. Baki CNS though I leave it to you because it's a short time. You may be able to revise, I don't know. But mostly cover everything from the sensory system: synapse, neurotransmitters, and sensory system. So receptors, ascending tracts, Brown-Sequard syndrome, syringomyelia, lesion of the spinal cord, all these questions. Okay. So that's how it is. Right. So thank you very much for attending this class. I really sincerely hope and wish that you crack this exam. My wishes are with you. All the best. We are with you. आपको कोई भी डाउट है, सोशल मीडिया प्लेटफॉर्म्स है PW के, आप हमसे कभी भी जुड़ो, कोई भी क्वेश्चन पूछो. एंड our own social media platforms are also there. You can DM me there, any doubt, anytime. Okay. Thank you. Thanks a lot. Bye bye. Hello.